Noswaith a chroeso. Good evening and welcome everyone to the first lecture in our 2023-24 series of Science and Health Public Lectures. We're very fortunate indeed to have our colleague, Professor Colin Dayan, to start off our new series. Colin wears several hats, not least of which are the Professorship of Clinical Diabetes and Metabolism at Cardiff University School of Medicine, the directorship of the Cardiff Joint Research Office, where he oversees clinical research in Cardiff University and the NHS Cardiff and Vale University Health Board. Remarkably, Colin also finds time to be a senior clinical researcher at the University of Oxford. He's also currently Clinical Research Secretary of the British Society of Immunology. Colin trained in medicine at University College Oxford and Guy's and Charing Cross hospitals in London before obtaining a PhD in the immunology of Graves' disease, an autoimmune condition, when he was in the laboratory of Sir Mark Feldman. He then spent a year as an endocrine fellow at the Massachusetts General Hospital in Boston, United States, before completing his specialist training in diabetes and endocrinology as a lecturer in Bristol. We're very fortunate that Colin took up his current position in Cardiff in 2010. Colin's clinical interests in diabetes are diverse and include the management of poor compliance and the immunopathology of type 1 diabetes. He also chairs the UK Clinical Studies Group for Prevention, Targets and Therapies in Type 1 Diabetes. However, it's type 2 diabetes and weight reduction that will be the themes of this evening's lecture. Before handing over to Colin, I just need to highlight a couple of housekeeping items. Firstly, we would like this session to be as interactive as possible, and so there's a Q&A function at the bottom of your Zoom screens where you can post questions anonymously of this evening's speaker. We will try to get to as many of your questions as possible. We also really value receiving feedback on our lectures, and you will therefore be sent a link immediately following this evening's lecture where we would kindly ask you to complete. So with further ado, over to you, Colin, please. And it's again a great honor to have you to open this evening's lecture. Thank you.
Well, thank you very much, James, and thank you for that very nice introduction. And as you can see from what James has just told you, I'm not a specialist in obesity. However, I'm very interested in it, and I deal with a lot of patients with obesity. And there's been some astonishing changes very recently in the drug treatment of obesity, which I think challenges us all. So that's why it's a great pleasure to share with you some of my thoughts about this and some of the recent discoveries tonight. I'll just share my screen. Hopefully this will work. Okay, so this is my topic here, novel weight loss drugs and obesity. You'll have to bear with me because the weight loss drugs will only come towards the end when I've told you a few things about obesity and understanding how we got into the fortunate position that we are in today. So, well, we all know about obesity. It's being fat, isn't it? And it's clearly a lifestyle problem. It's just because, well, people just eat too many sweets and junk food. And, well, there's not much more to it than that, really. It's their own fault. Well, the science doesn't really back that up. Let's look a little bit. What we do know, though, is that obesity has bad effects. And as James implied, the reason I end up being interested in it is because one of its strongest effects is in producing diabetes. But here are other effects that are associated with it. The diabetes comes from insulin resistance, but it also increases your risk of things like cancer and heart disease. And actually, it's one of the commonest causes now of liver cirrhosis as well. So I wanted to show you a bit about what's been called the obesity epidemic. And I'm going to show this to you by showing you the weight of America. So this is data from the Center for Disease Control in America, which collects data from all the states of America. And here we are in 1985. And what it's showing you here is the percentage of people, of adults in the population, who are what's described as technically obese. So in their definition, it's more than 30 pounds overweight, because they use pounds and not kilos, or a body mass index, which is your weight divided by your height squared, more than 30. So that adjusts you, if you like, to tall people, adjust their weight for taller people. So here we start in 1985. There's many states that didn't collect enough information, so they're white. But where they did, it was either less than 10% or 10 to 14% of the population was obese. Now, come on the journey with me. So here's 1986, 1987, 1988. So this is year by year, 1989, 1990. And we get to 1991, so just 6 years into this journey, and we need a new category of 15 to 19%, because several of these states, I'm not going to do a geography lesson here, but I think we've got Louisiana and Mississippi there, that have now 15 to 19% of their population is obese. And as we go through, that begins to spread, it seems, from the east over to the west, until by 1997, another 6 years, we need another new category. And that spreads as well. So year by year, 2001, another new category, spreading a little bit further. Here we go. No, 2005, it's happening more quickly now. We need another new category. So now more than 30% of the population is obese. And then and spreading again here, and then more than 30% obese. And if we look over from all of those years, in fact, just from 1990, where we had most of the data collected, there were still a few states that didn't have all the data, right through to 2006, you can see the dramatic change that's happened in those years, in those 16 years. And in fact, there is data now up to 2019. And in 2019, we now need another category of more than 35% in the obese category. And here's many of the states that are showing that amount. So, and all of them, except maybe Colorado, which is less than 20%, but all of them are way higher than they were in 1990. I'm just showing you this really to illustrate the speed at which we've been gaining weight. There's some other interesting facts about obesity. And this is one I find very interesting. There is actually a correlation between obesity and speaking English. Apparently it correlates pretty well, but that's more to do with the English and Anglo-Saxon nations. So here's France, for example, with obesity rates that are half the obesity rates that we have in the UK. And in fact, I'm afraid to say that the UK is the fattest country in Europe. And I'm especially ashamed to say, or afraid to say, James, that actually Wales is the fattest country in Europe. We'll leave out Turkey for the moment. But you can see here's all the other European countries. Always interesting that the southern European countries often are not as overweight. This is showing you rates of diabetes, which I'm not going to talk more about today, but obviously there was a strong correlation between type 2 diabetes, as James said, and obesity. So what is driving this? Well, money. So here is the increase in per capita wealth from 1961 through to 2009, and we're all earning, not all of us, but gradually more income, either per capita or the median household income has gradually increased over this time. That means that we can buy more food. And that is what we're doing. We're consuming more energy. So you can't actually measure what people eat, but this is called the daily per capita food supply by world region, which is the average basis of the average calorie supply to individuals. It's not exactly consumption, but it's close to it. So what you can see is that again has increased from around 2,000 calories now, and now in North America it's really more about 3,500 calories, or a little bit higher than that. North America's topped the list over there, and here's the developing nations over here, but they're all increasing as well, and they're all increasing in weight too. So that all seems very straightforward. We're just eating more. So obesity then is an environmental problem. It can't be a genetic problem because genetics doesn't change that quickly. In 16 years, people's genes don't change. So you can view it maybe like this, that we're surrounded by calories. When you go and fill up your car, they do hide the cigarettes away from you behind the counter, but they don't hide the wall of calories, which you have to walk by. And of course, most people now can actually afford to just pick a few extra calories off, even if it's not part of their meal. So many people think, well, there we are. That's the whole explanation of obesity. It's an environmental problem fueled by us having more money to buy more calories. And maybe that's supported by data such as this. This shows people in rural Cameroon, so in West Africa, in the poorer areas, and in the the cities of Cameroon, you can see their body mass index has already increased. And then in the same people with the same genetics in Jamaica, courtesy of the British Empire, moving them over from Cameroon to Jamaica, but genetically similar. But when they come to the UK, the same population has a higher BMI. So this all seems to fit with the environment they're in. And over here, I'm just showing you the prevalence of diabetes, which has actually increased tenfold as they've moved from rural Cameroon into the UK. So we said here, the richer you are, the more you eat and the less you do. And so we come back to this idea that it's just a lifestyle problem and we could reverse it by just a bit more moral fiber. And what do you need for moral fiber? You need to go on a diet. So, of course, that's been the cornerstone of the management of overweight as it's become a problem over the years. And really, it doesn't work. So here's a collection of different diets that have been put together. It's showing you the weight loss at the end of the diet and then for the next 5 years. And in almost all cases, people revert to where they were after 5 years later. And in fact, they actually overshoot. So they're actually a little bit heavier than they were than before they actually started the diet. So I often say, well, don't call it a diet because that sounds like it's temporary. It's something you're going to do. You're going to have to re-engineer and do long term. So whatever you do, it doesn't seem to be permanent. So I'd like to introduce a few of my heroes now, or heroines. And this one here is Roy Tellier, who's a diabetes physician from Newcastle. He's standing next to his MRI scanner. And he was famous for understanding the association between obesity and diabetes and showed that the liver and the pancreas end up having fat in them, which shouldn't be there. It should be in the fat cells in your tummy and so on. But in fact, when you have too much of it, it spreads to the pancreas and the liver, and that's what gives you diabetes. So he solved this by saying, well, what you need to do, and I have to say Roy is very lean, is to go to a very low calorie diet, 600 kilocalories a day. That's much lower than the diets I was just showing you. And then you can gradually progress on to vegetable dishes. So this is what you get. And there you are, your 600 calories meal replacement. You don't even get the pleasure of a meal. And then you get the vegetables as you gradually wean yourself off. And then you can go on to some particularly low calorie foods after that. And over the last few years, this has really been trumpeted, and Roy has really led it and done some clinical trials. And it's astonishing that what you can see here is that in his clinical trial here, he looked at the percentage of people losing 15 kilos. Remember that number, 15 kilos. We're going to come back to it many times. But as you might expect, 15 kilos is a lot, right? That's 2.5 stone. And none of the control group, who didn't get these meal replacements and vegetables, lost that amount of weight, and about a quarter of the intervention group managed to do this. And if you look down here, this is the different amounts of weight that they achieved here, and what they managed to do in terms of, these were people with diabetes going into remission with the diabetes, which meant they could come off their tablets for their diabetes here. And you can see if they managed to lose this magical 15 kilos, then the vast majority of them could reverse their diabetes, which was really important. So losing a large amount of weight here, 10 or 15 kilos, in people who are pretty overweight at the beginning was very beneficial in terms, in this case, of their diabetes. Note here that Roy's colleague, Mike Lean from Glasgow, also helped with this, and he's very aptly named as well. Okay, well, the trouble is that all of this has been associated with this idea that obesity is laziness, it's a lack of moral fiber, it's got a huge amount of stigma, it's all your personal choices, it's just you. Now, before we make those judgments, I want to take you back now to 1976. And Dr. Borison here in Malmö County Council, Malmö County in Lund in southern Sweden, and he was a pediatrician who looked at 101 twin pairs. So here are some of the twins pairs that he looked at. Just to introduce to you the difference here. So on the bottom, this is monozygotic twins, which is what you will think of as identical twins. It means that they came from the same egg that then split apart in the uterus. And it means all the genes are the same between the twins. That's why they're identical. But you can have other twins as well, which are dizygotic. And that's where the mother had 2 eggs that were fertilized by 2 separate sperm at the same time in the same uterus. So basically they're brothers and sisters, in the womb who were born at the same time. So they don't even have to be the same sex when they're dizygotic. Absolutely, for monozygotic, they have to be the same sex. So these are like brothers and sisters who are the same age. These are identical. They're clones, if you like, of each other. And what can you see from this picture that he observed? And that was, if you look at dizygotic twins, quite often they're quite different in body weight. So, for example, here, for example, here, for example, they're often different in height as well, not really surprising. And there were many examples here of quite big differences in body weight. By contrast, with the monozygotic twins, they were very similar. And you can see that from the picture here. You're hardly able to tell who's who in these. They're very similar in weight. And when he did some statistical analysis, I'll just help you with the maths here. He's looking at the standard deviation. And so if the standard deviation is big, there's a lot of variety. Whereas if the standard deviation number is very small, then the twins are very similar to each other. MZ is monozygotic, DZ is dizygotic. And he only had 11 and 16 here, but he could tell at the age of 7 that they were much more likely to be similar in weight than the dizygotic twins, and it was even more so when they got to the age of 11. So it was much smaller standard deviation than in the dizygotic twins. So this is telling you that there seems to be a genetic component, because usually these are in the same family. Well, it was interesting that quite a few years later, in 1990, Stunkard and colleagues did this fascinating study where they looked at twins who have been reared together and reared apart. So this is the idea that they've changed their environment. You took them, and for whatever reason, they were in different families as opposed to being in the same family. So here we got, again, monozygotic twins. And if they're reared apart or reared together, now this number here is a correlation number. So 1 is perfect correlation. They're exactly the same weight. 0.7 is very high, so they're very similar. So you can see the dizygotic twins here, the number is a lot lower. So the chance of them being similar in body weight is much, much less. And that's the same whether it were men or women. But the amazing thing is it didn't matter whether they were reared apart or reared together. We've taken the environment out of this altogether. Identical twins, if you separate them and they live in different families, they're fed in different ways, they end up the same weight. And look at the number of pairs. They had quite a lot of pairs here. This wasn't a small study. So that's an amazing observation, that it does seem that genetics has got a large part to play, more than the environment. And this was their conclusion. We conclude that genetic influences on body mass index are substantial, whereas the childhood environment has little or no influence. These findings corroborate and extend the results of earlier studies of twins and adoptees. I'm sure in the Q&A we'll have a lot of argument about this, but that was an astonishing finding at the time, but strongly supported by the science. Well, so we need to understand. What that said is that there is something to understand about obesity. It's not just about whether people decide to eat high-calorie foods or not. And this was illustrated by the finding of obese mice. And this is a famous mouse, the ob obese mouse, which is huge. And it's so huge that it can't even copulate. It can't reproduce. You have to rederive the lines until they're homozygous like this. So that's a normal mouse. And this is a hugely overweight mouse. And what they discovered is that this mouse is lacking in a hormone called leptin. So here is leptin. So now I've taken you forward actually to 1994. That's where we are at the moment, 1994. And when I remember this being discovered and thinking, what, we've cracked it now, we know what causes obesity. So leptin is a hormone that comes from fat cells. Well, that makes a lot of sense. And when the fat cells are empty, they don't make much leptin. The leptin goes to the brain, and it acts in a very small region, which is absolutely critical to controlling weight, called the hypothalamus, which is at the bottom of the brain. And when there's no leptin, the hypothalamus encourages you to eat and increases your appetite. When the fat cells are full, then the leptin signal is sent to the brain, and the leptin then stops you eating. And so it does that by controlling your appetite. Very clever system. It means the brain knows how fat you are and how full the fat cells are. So that seems to be a good way of doing it. And then in the subsequent years, they really learned incredible amounts of the detailed nervous system chemistry that drives it. And I'm showing you an overview of it here. So these are different neurons here producing different things. And one of them would act on the neurons in the hypothalamus saying eat, and the other one would say stop eating. And an important signal for stop eating is a hormone, or sorry, neurotransmitter that binds to this, the melanocortin-4 receptor. So when they realize this is the way that leptin works, there's a couple of things now that you can do. So, and I'd like to introduce more of my heroes or heroines. Steve Bloom, and they're actually almost 3 generations older than each other. So Steve Bloom was at the Hammersmith Hospital for many years, and he discovered a lot about gut hormones. I haven't mentioned gut hormones yet, so Steve, you'll have to wait, because although you discovered a lot, people didn't realize what you discovered until much more recently. Steve O'Rahilly is a lovely guy, Irish guy, who works in Cambridge, and he worked on things like leptin and the genes that control body weight. And in fact, for many years, they collected the most extremely obese kids that they could find to look for genes that were causing obesity. And Sadaf Farooqi then joined him, and she's an absolutely wonderful investigator too. And what I love about Sadaf is that she's apparently went for a Medical Research Council fellowship, and they said to her, yeah, you're very, very clever, Dr. Farooqi. What would you like to research? And she said, I'd like to research the control of body weight. And apparently they all fell about laughing on the panel at this point. They said, well, there's nothing to it, Dr. Farooqi. They're just fat because they eat too much. How wrong were they? Anyway, Sadaf went on and became an absolutely internationally known investigator in this area. So one of the things they did discover was that there are leptin deficient children. So this is a child with a mutation in the leptin gene, so they can't make leptin. There's also some that have a mutation in the leptin receptor, and they are enormous, and they can't stop eating. They eat and eat and eat. And as Sadaf has said in one of her lectures, interesting enough, they can't tell the difference between broccoli and chocolate cake. They will eat anything. Their parents have to lock the fridge. They have to hide all the food away because the kids cannot stop eating. This is not lack of moral fiber. This is the enormous drive when your appetite is not satiated. And then they went on to clone the gene for leptin and identify the sequence, and that allowed them to treat the children. And quite remarkably here, if you give injections of leptin to these children, this is the same child, believe it or not, they lose weight. So this is a very biological mechanism. And there was a feeling at this point that leptin was going to be the answer. It isn't, for reasons I'll discuss in a moment, but clearly there is important mechanisms biologically controlling body weight. It is actually the answer for these children who have this genetic mutation, but they're the minority. But actually, amazingly now, they have discovered a drug called setmelanotide, which mimics, you remember, back to the melanocortin-4 receptor. So instead of having to give leptin and start all this process up here, you can give a drug that acts directly in the brain. And it does this because there are other ways, other genetic mutations that result in poor control of body weight. And this works for many of them. And this has now been marketed, licensed in 2020 in America, 2021 in Europe, and is now available and is transformational for these kids who are having huge problems with their body weight. And here's actually a clinical trial of POMC, of the setmelanotide, shown here. And it's, again, amazing changes in body weight. So if you can see it here, up the left-hand side is weight, and many of these were children, remember. So this is weight change, 10 kilos, 20 kilos, 30 kilos. And here they are. This is measured now in months. So within 7 months, I think it was, because these are different visits here, they lost around 25 kilos. And then they had a little placebo moment where they stopped the drug. And this is actually showing you hunger scores along the right-hand side here. So the hunger scores went up again, the body weight went up again, but then they restarted and they managed to maintain that loss in body weight. This is hugely different from those dietary studies that you saw earlier on. This is maintenance of body weight biologically by giving back what was actually missing in this particular situation. All right, I want to switch a little bit because this is now what they discovered about. We know about the importance of genetics, and there definitely is genes driving things. And that really focused us on the biology that drives the control of obesity. But it is not really what drives the obesity for most of us. Meanwhile, the surgeons have been at work, and people have been trying other treatments for obesity, and the surgeons have been developing lots of treatments. In the 60s, 70s, they did what was called malabsorptive surgery, which is basically they cut out a lot of your gut so you couldn't actually absorb the food. And that kind of made sense. And it did make you lose weight, and certainly, but there was huge problems with malnutrition and failure to absorb nutrients and vitamins. And it was a really quite a dangerous thing to do. And of course, once you've done it, you can't put the gut back. But gradually they tried different things. So they thought the main thing was to stop the food getting in. So they tried things like jaw wiring, but then they moved on to this one, a gastric band. So that's obstructing the way into the stomach. So the food makes you feel full very quickly. And that did actually seem to work. As soon as you took the band off, it got reversed. But then they started to do some rather strange things. So they diverted the food. Here's your esophagus here, round the stomach and into the small bowel. So it rapidly, it bypassed the stomach altogether. And then they did things like removing the stomach, and the stomach's main role is to slow the food so that it can be digested more carefully. But that was the idea, that you take out the stomach or you bypass it, and it won't be digested as much, you won't absorb as much. In fact, these are not malabsorptive surgeries. You do absorb almost all your food in the small bowel. There's another 22 feet of it below here. So actually all the food was absorbed. But these surgeries were incredibly effective in weight loss. And here's one called a biliopancreatic diversion or switch operation, in which they've not only removed the stomach, they've done a diversion as well. And it's a much more extensive surgery because now the food starts even further down the gut. Now, believe it or not, so they did work. And this is a thing called the Swedish obesity study, which is a very famous study here, because look along the bottom, this is 10 years. This is not 1 year or 2 years. This is 10 years. Here's the controls. They didn't change weight. Actually, that's a really important thing to notice. We all control our weight actually very stably, unless we get very sick or very stressed. But in between, our weight is very stable, very similar to those twin pairs that you saw earlier on. Anyway, the ones that had the surgery, so this was gastric banding. This is vertical banding gastroplasty, but here's one of those bypass operations. Look at this now. This is 10 years later, they're 30% lighter. Now, if you started at 100 kilos, that is 30 kilos. Remember Roy Taylor and Mike Lean, and they were excited if you got to 15%. Here's the surgery, and it's maintaining this right out to this 10 years. And this is the mean, which means that, at least 50% of people got to this point. So that's way better than the meal treatments. Okay. But people began to ask the question, how does this work? And I emphasize to you that the most important thing that it does is to get the food very quickly into the small bowel. And people began to realize that the reason that that was effective is it made you feel full. So the clue was that what happens in your small bowel gives you signals to say you've eaten enough. So as the food comes into the stomach, it reduces your feeling full to some degree, but it's really when it gets into the small bowel that it says to you, hang on, that's enough. You don't need to eat anymore. And when you're not hungry, you don't eat. It is possible to override it, but the appetite signals are so strong that even these people here, who were very overweight at the beginning, I had a patient who weighed 176 kilos and lost 76 kilos following this kind of surgery. That is not improving his moral fiber, but that's a very strong biological effect. So as people reflected on this, it came actually back to Steve Bloom. And Steve had been working for many years identifying lots of hormones that are released from the gut. Now, people didn't think that the gut was a place that hormones were released from. And he measured all of these things. And people said, Steve, that's really interesting, but it's really rather pointless. And they thought that most of these hormones, what they were doing is controlling the speed at which the gut motility happened, how quickly the food moves through. And definitely does do that. These hormones do control the speed of contractions within the gut. But gradually they realized there was much more to this than that. And perhaps that's better shown here on this slide here, they realized that one of them, ghrelin, which is in the stomach, was an appetite stimulus, but all of the rest was strongly satiating. They were strong signals that made you feel full and stopped you eating anymore. And you can probably guess where they act to do this. They act on the hypothalamus in the brain. That's where they're going to go. They're least released from the circulation in order to do that. Ghrelin's interesting. It's sometimes called the hunger hormone because it's when your stomach is empty, it tells you you're hungry. And when it gets full, it switches off the ghrelin. So actually, strange enough, when the surgeons did their surgery, removing some of the ghrelin was also helpful as well because it removed that hunger element as well. So in fact, they were doing, if you remember back to the surgery, not knowing what they were really doing, they were cutting out the ghrelin here and putting the food very rapidly down into the small bowel where, and you can see from that sort of graph, that, and over here, for example, that many of these are not released until quite low down. So if you make the food go immediately there, then within minutes after eating, you feel full. And this is a tricky, a detailed diagram, but I just wanted to show you because I think it's amazing what the body does. So this is the lining of the gut. Can you see these cells here? So the food is out there and the rest of the gut is in here. And most of them are in the gut lining is there to absorb the food. That's what it's supposed to be there for. But there are a few like these who are called enterochromaffin cells, these blue ones here, and they make the gut hormones. And when they've studied them in a lot of detail, they have very clever receptors, for example, for amino acids, or these are fatty acids, long-chain fatty acids, short-chain fatty acids, things like that, and glucose, so that they can detect what's in your food. And as these receptors detect it, they then control the amount of gut hormones that they secrete. I'm not going to tell you that's exactly how the patients do the difference between broccoli and cake, but it is partly the way you feel full for something and not for other things, and the way the gut can work out what it is that you've eaten. So back to our surgery. Well, then we should be able to achieve everything the surgeon does without surgery, if we can actually repeat it using the right chemicals. So people started to make these. They were originally designed for diabetes, which is why we got involved with it. I was very interested in it and so on. So if you've been very attentive, I'm going to have to go back now, you'll remember some of the names. So for example, one of them, I'm going to go back one more slide here. One of them was called glucagon-like peptide 1. They were named for all the wrong reasons, but anyway, that's why. And there's another one here called GIP. So remember GIP, remember GLP-1. So one of the first ones they made was an analog of GLP-1. This is the first one, actually, Exendin, or Exendin 4. And it was actually found in a lizard that actually made this version of something like GLP-1. This is the actual GLP-1. But it had to be different because otherwise it was destroyed within minutes in the body. So it made a long-acting version of that. So they made different versions of this, which is long-acting GLP-1. And they gave it to people. And I'm going to skip over many years now because we've been using this for diabetes for over 10 years. But we did notice that when we gave it to people with diabetes, and we gave it to them because we noticed it actually stimulated insulin, not because we were interested in weight loss. But people then began to realize that it did produce weight loss. And then one of those, which was particularly powerful, called semaglutide, was then the company said, oh, the doses are 0.25, 0.5, 1 milligram. But they said, why don't we try more to get more weight loss? So here is a study of once weekly 2.4 milligrams of semaglutide. So once weekly, it's an injection given under the skin, like you might get insulin, given once a week. That's it. That's the only treatment, sorry. And the results were quite remarkable. And this is actually data from 2021. So it's actually very recent here. So here's the placebo again. Now you're getting used to percentage changes from baseline. So 15% is a big number, right? And with diets, 5% or 5 kilos, if you're 100 kilos, it's pretty good. Well, here's semaglutide. And so by the time they got to 6 months here and then 1 year out here, they'd lost on average 15% of the body weight, which is getting very similar to what you saw in the for the surgery. So that was just remarkable. And this is on the basis of this trial, it got marketed. And you'll know now, probably many of you know the name Wegovy. And so they called it semaglutide, but gave it a different name. It's called Ozempic when it's given for diabetes and Wegovy when it's given for obesity. And it has now been licensed by NICE for obesity here. And here it is. You have your pen, you inject it once a week. And you know, it's been all over the news here. And so here it is. NICE recommended it in February 2022 that you can get it on the NHS and you can buy it as well independently. And in fact, that was a problem because, of course, now there were lots of people in private clinics wanting to use Wegovy. You might want to say, well, there can be no free lunch. Surely, Colin, you can't just, can't be just as easy as that. There are side effects because it's having these effects on the gut and slowing them and so forth. So these are the common side effects. But although many people do experience particularly nausea, sometimes vomiting, it often settles. And that's why you have to increase the dose very gradually. So as you increase it gradually, they get used to it, but continue to get the benefit. What's not listed in here, if you like, is any really dangerous side effects. And some of the older drugs that operated directly on the brain caused depression and suicide, but you don't see that with Wegovy. So I just wanted to show you a little bit the economics of Wegovy. So this is Ozempic and Wegovy patients' growth in obesity. So what this is showing is the amount of Wegovy or Ozempic that was prescribed for obesity versus the prescription for diabetes. And what you could see here is that over time, the prescriptions here, this is over months of 2022, for obesity overtook them. And as a result of that, we now can't get it for patients with diabetes. It's almost impossible to start a new patient on any of these kind of drugs, Ozempic, for example, because they just didn't make enough. They couldn't believe how effective it was and how many people wanted this. Here's the shares of Novonordisk, the company, increased over just the period from 2021 to 2023. And in fact, here, it was announced just a few months ago, Wegovy makes Novonordisk becomes Europe's most valuable firm, valued at $428 billion. So this one drug that was designed for diabetes and then just got a bit carried away with itself is suddenly the first drug that causes remarkably sustained weight loss. But the story doesn't stop there. That's old hat now. We've gone way beyond this, believe it or not, although it hasn't quite reached the everyday clinic. So I showed you these drugs, GLP-1, extended. I haven't shown you semaglutide, but it's a version of this. But the next generation was this drug here called tirzepatide. Now, tirzepatide, here, sorry, I'll just skip on a little bit. Oh, I haven't got it. Tirzepatide, oh, sorry, I showed you here, is a joint GLP-1, which is what these were, and GIP receptor agonist. So it's mimicking two hormones at the same time. In fact, most people thought GIP wasn't really very important in weight, but they thought this is a good idea to actually have one molecule that can hit both receptors. So that's what they developed. And way were they blown away. So here is the comparison to tirzepatide given once a week with that old stuff, semaglutide, Wegovy given once a week. So here's the line, semaglutide, 1 milligram, in this case over 40 weeks. They didn't compare it, in fact, to the 2.4 milligrams, which is a higher dose over there. But at least at this dose, tirzepatide was more effective here. And here in this particular study at the top dose, it's causing within about 6 months, again, about a 15-kilo weight loss. And in the head-to-head studies, tirzepatide has been more effective than semaglutide. And then just in the last year or two, Lilly, who made tirzepatide, have actually tried a triple agonist. So this one goes for the GLP-1 receptor, the GIP receptor, and another receptor called the glucagon receptor. And they make this triple agonist over here. The glucagon possibly has an effect on energy activity. And I haven't talked at all about energy expenditure. I've just focused on body weight. But in fact, the most recent data means it's although in the mouse, you can see an effect on energy expenditure, there's very little effective evidence that that is what's happening in humans. And here is some of the data just reported in June 2023 for retatrutide, which is this triple agonist for obesity. Okay, so back to here, we're getting used to this kind of thing. So here's the lines down. Can you see we're now at 24 weeks down at nearly 20%, but it's not stopped there. It's not leveled out. And by 48 weeks, we're talking about 25% body weight. This is now almost as good as any of the best surgery. And here, Roy Taylor, is the number of them that lost 15% of body weight. Do you remember I told you to remember 15% or 15 kilos? And Roy, with his meal replacements, managed to get about 24% of people to achieve 15% of body weight reduction. And here with the drug, with the top dose of the drug here, retatrutide, 83% of them achieved a 15% body weight. 100% received more than 5%. So 100%, you never see that number. And that means it's working in everybody to some degree. And here, 26% losing 30% of their body weight. So that's 30 kilos, or really about 5 stone in weight. And in fact, most recently, just last month, they've made an oral version, a tablet version of the GLP-1 receptor called, difficult to pronounce here, but orforglipron. That's what it looks like if you want to know chemically what it looks like. And that seems to work pretty well as well. So this is not an injection, it's a tablet. Overall mean body weight reduction for 199 kilo male here, and then using down here to 14.7% loss in body weight here, similar in males and females. This is sort of absolute change. So if we have these kind of drugs, why shouldn't we be whatever way we want? Why can't we make them available to everybody? Oh, because it's not natural. Oh, because it's not ethical. Oh, because it must be dangerous. But we haven't found that it's definitely dangerous. And anyway, you shouldn't be doing this because this is a lifestyle disease and they should pull themselves together, which looking at that twin data and that genetic data is clearly showing that's not the case. So what it looks like is we all have these genes. We all have an ability to reach our obesity potential, if you like, which is what you were seeing in America over those many years. But 40 or 50 years ago, we just didn't have the money and the exposure to enough food and calories to do that. Now we have calories that are very available. It's very easy to eat them quickly and for them to trick our satiety. So it's very difficult in that situation to control body weight, and it varies between individuals. Now we have treatments that can control that and can make huge differences. So here's my summary, and then I'll go over to take some questions. So my summary is weight is tightly controlled by outstandingly clever control systems in the body. It's not just about what you've just eaten. It knows a lot about what you're eating, and the appetite control particularly is very powerful. The main control is via appetite rather than by energy expenditure. Appetite is strongly regulated by gut peptides, and I've shown you some of those gut peptides and the enormous effects that they can have. New drugs mimicking one or more of the gut peptides appear to offer highly effective and safe treatments for weight modulation. And my question is, what should we do with them? Just before we go to the questions, I would say that food is actually a pleasure. It's one of the great things that we enjoy. And many people who have bariatric surgery are not very happy after their surgery. They're pleased with the weight loss because they almost all get weight loss, but it's taken away something that was often a friend and gave them reassurance and gave them a lot of pleasure. When you suppress the appetite like this, you're not really interested in food and you don't get much pleasure out of it. So in that sense, it isn't a completely free ride. And that is sometimes the reason that people don't like this. But one of the things about the drugs, as I've shown you, is they're completely reversible, unlike the surgery. So I'll stop there and take some questions.
Thanks, Colin. That was absolutely fascinating. A real tour de force there. And I'm sure it's provoked a lot of thoughts and questions in our audience. And those questions, please, would you kindly start sending them in via the Q&A? So maybe, Colin, I could quickly start off then. So it's estimated that already 1% of the population of Denmark are on these weight loss drugs, one or other. What do you, if you were to gaze into a crystal ball, how do you see things evolving in the UK? What's going to happen in the near term and in the long term?
Let me just illustrate something else, James, and that might come back to it. So about 30 years ago, we didn't have many good drugs to treat cholesterol. And then statins came out and people said, got to keep those with very high levels of cholesterol. People are really in big trouble, etc., etc. Eventually, the statins came off patent, and they cost almost nothing. They were sold over the counter for a while, and they are spectacularly effective at reducing mortality. And certainly almost all our patients with diabetes are on statins. I don't know the exact number in the population, but I suspect it's way over 10 to 20% are already on statins. And it's resulted in significant improvements in longevity. Now, people say, well, it's not natural. I know my father once used to say to me as he gulped his tablets down, I'm only here because of the tablets. Well, yeah, but we weren't designed to go beyond 45. So you do need some medication to get yourself a little bit further on. So let's imagine, forget the cost. Tirzepatide is a problem because it's being charged at a lot of money in the States. And remember that the cost of a drug is nothing to do with how much it costs to make. It's how much they can get away with. So it doesn't cost that much to make peptides like this. So it costs a lot to discover them. So I think you need to imagine, what if it costs pretty much nothing? What would we do with it then, James? Who would we not give it to? And if it is as safe as, for example, statins turn out to be, and I'm sure there's going to be some glitches along the way, then why can't we sell it over the counter and people can take it as much or as little as they want to? If that happened, I think it could be 10 or 20% of the population.
Could you just repeat that again?
I think if that happened, it could be 10 or 20% of the population on
Really?
these drugs, probably having to wait till they're off patent. And you could do the tablet. You saw the tablet at the end there, so you could pop that each day.
And do you think down the road, Colin, there would be prospects for people initially using the drugs to bring their weight down, but then something coming along whereby you can then come off the drug and still remain,
No.
It's never going to work. It's never going to be as good as that.
I think it's going to reverse. I mean, maybe that would be an even cleverer thing. But, that's resetting the set point for things like blood pressure and cholesterol. So we've never learned how to do that. We know how to control it. So I'm kidding a little bit. I'm winding you up. But I think it will require continued treatment. We've got a few things in the chat, I think.
Yeah. So there's a question here about, is there any relation between genetics and the microbiome? Does the microbiome have a role in weight control?
Well, I'm not really an expert in this. There's a lot of discussion. So the microbiome, for those who don't know, is all the bugs that you have in your gut. So it's your collection of gut. And it's a huge number of bugs that you have in your gut and also on your skin as well, and in other places in the body that are not sterile. And people are very interested as to whether, that collection of symbiotic bugs that like to live with you has an effect. Certainly, they do metabolize some of the foods that you eat. So I think it does have some effect. But at the moment, there's very little evidence that this can produce the big changes that we're seeing with the other drugs.
Thanks, Colin. In your opinion, do you think weight is more to do with genes compared with just eating a lot?
Great question. So, well, what do you think that study from 1976 showed? What it shows probably is that the genes have an effect on your set point for your satiety. So that some people are full much more readily, some people less readily. And if you surround them with the wall of chocolate, some people are going to feel desperate, some people are not. But what it shows you, what I was trying to show the other way around, is once the appetite kicks in, you don't want to eat. So for many people who are very thin, it's not difficult. They just don't want to eat this kind of amount of food. Other people, like those kids, right, with the leptin deficiency, they cannot stop. They're going to find their way through the broccoli and the cake. So when you ask that kind of question, I think that there is a very strong biological basis to it. I think that's what I'm trying to argue, rather than just a cultural basis.
Thank you.
There is, of course, I'm going to point out, there is a cultural basis because, of course, France and the UK are double the difference, and we're not going to have a discussion about that. So there are some cultural elements.
Yes. Where do ultra-processed foods fit in this story, please?
Well, ultra-processed, I guess I'm going to take a step back from that and really talk about calorie-dense foods. So I said that we enjoy eating. It's one of life's great pleasures, isn't it? I mean, that's exactly how you train dogs, is on food, because it gives them such great pleasure. And so, of course, we've learned to cook things that are nice. And particularly things like the fast foods are very attractive. So they actually they feel attractive to your taste, but they're often not so quick at reducing your satiety. So you can eat more calories before you feel full. When I was a student, I went on an elective to Kenya, and they had the main staple diet was ugali. Now, some people on the call may know what ugali is, but I can tell you it's like a mealy meal. This is completely monotonous. And there was a tiny bit of chicken in the corner. I'm going to swear you cannot get overweight on ugali because it just takes such a long time to eat the calories that you need to. By contrast, calorie-dense foods allow you to consume very large amounts of calories, almost tricking your appetite. Now, the ultra-processed foods, a lot of people are talking about how those things have hidden in them things like salt and so on, which are also problems within the diet. I think we're really talking about the calorie content rather than the other elements in that diet.
Thank you,
There's a question about setmelanotide, whether it's still being used, and it certainly is. In fact, it's only been licensed 2 years ago, but it's not used in common or garden obesity. It's only in the genetic obesity.
There's another question relating to pharmaceuticals, Colin. Is Saxenda a good drug for weight loss? Is asking.
These are all related drugs to the GLP-1 agonists, and they're all good, but they're getting better. So tirzepatide, I mean, I've just come away from the European Association for the Study of Diabetes in Hamburg. The place was buzzing about these drugs because, as I was saying, that Wegovy is actually going to look like a small beer compared to the newer drugs. So Saxenda is one of the original Ozempic-related drugs.
Great. Colin, can these weight loss drugs become unuseful when they become normalized? I'm not sure if the individual is meaning, can you become toxic so they no longer have an effect?
It's a great question, really good, because most things, can't last forever. The honeymoon can't last forever, but it does. As far as we can tell, it does. Look at those. I mean, we don't have 10 years of data on these drugs, so we have to say that. And I want to answer maybe James's earlier question. I don't want 20% of the population on it now, because if there is something that occurs in 1 in 100,000 people, we'll have a lot of problems there if it causes liver failure or something in a small number of the population. So it's better that it builds up gradually. But I showed you the bariatric surgery data, and if you believe that surgery, the weight loss surgery data, is mediated in the way that I've just said, in other words, through these hormones, it doesn't wear off. It's not that jaw wiring always wore off. As soon as you undid the jaws, they went back again. And when you undo the band, it goes back again. But it seems, because it's using a natural system, that it seems to persist.
Slightly different tack, Colin. Do you believe people will become over-dependent on these drugs and not rely on natural instincts to keep your body healthy? In other words, are we going against the public health message of...
Yeah, but this is natural instincts. This is your appetite, right? The trouble is that your natural instincts are not good in a society that is replete with calories. They're not a survival instinct. We were designed to hunt food and be desperate for food and be hungry all the time. That's what we were designed to do, not to be surrounded by, the wall of calories. So our natural instincts don't work in our current environments. That's what I would argue. I'm very happy for people to have a go at it.
Is there not an argument for combining these drugs with exercise and trying to still eat certain healthy foods?
Okay. I have been careful not to say that exercise is not necessary. And of course it is necessary. Exercise has lots of other effects on the cardiovascular system. Losing weight can do that, but it doesn't increase your fitness. And your fitness reduces things like blood pressure, increases longevity, reduces things like the risk of dementia and so on. So exercise is still very important. So if what it's referring to is, can we sit on the couch and eat all day? Notice one thing though, we can't sit on the couch and enjoy eating all day. And these are not drugs that will give you the chance to eat the whole of McDonald's and not change weight, because they're not controlling energy metabolism. That's still a bit of a holy grail that people haven't got to yet.
When a doctor is able to prescribe these medicines? Well,
so they can, right? So they can prescribe Ozempic now, today, tomorrow. In the UK, the problem is that I'm not supposed to prescribe for people who don't have an indication that NICE has said. So, to give it to people who are not particularly overweight because they fancy losing weight, then that should not be funded by the government. So you'd have to pay for it yourself. But it is still a licensed drug. And for obesity, I can prescribe it as a doctor. Everyone can prescribe it. And so that's why the private sector has been prescribing it, but people have to pay for it. So it is now available. And now it's in the, what are called the tier 3 weight management clinics. So if you want it on the NHS, you have to go through your GP, who has to refer you to a weight management clinic, who will discuss diet and exercise for a certain length of time. And when that's not effective, they may consider discussing whether these drugs, and at the moment surgery as well, would be an option for you. And they're going to weigh up your benefits and risks. So if you're only slightly overweight but would like to lose a bit of weight, then you're not going to get it from the doctor in that particular circumstance.
Yeah. And a related question then, how sensible is the NHS policy of limiting Wegovy to 2 years? So could you just kind of give us the background there? Is that the current?
I don't know where that came from. I mean, okay. I don't understand it, right? It's not going to work. But I think the feeling was, it's back to this idea, and these are just my views, I'm not speaking for the whole UK government here, is that it's the idea that it's still a pull yourself together disease, that we're given 2 years, you can lose the weight, and then you can pull yourself together and control your diet after that. I don't think there's any evidence that that's going to work. And so also, all the long-term health benefits won't be realized doing that, because you want to do it for longer. In this context, a lot of it is for people with diabetes, and it can, at that point, reduce their need for diabetes medications. But I don't think it'll be a long-term solution.
So, Colin, I think this is a question that many of us on the call might, on the webinar, might be thinking that someone's asked. If someone with normal weight, a little bit overweight, takes these tablets, would they have similar results?
Well, I don't think I can lose 40 kilos. Because obviously, in the end, what you're losing mostly is fat mass. When you starve, when you're ill in hospital, you lose muscle mass and fat mass. The body is quite good when it's not eating at selectively losing fat, because that's the design, of course. Fat is where you store your food, right? And we were designed to be able to not eat for 3 weeks. So during that period of time, we burn up very little of the protein, but actually lose predominantly the fat. So, but there's a maximum amount that you can lose, and you can only lose your fat mass up to a certain point. You need to have your muscles and you need to have your bones and so on. So they would lose less than people who've got a much bigger fat mass at the beginning, but they would lose.
So if someone, is thinking of getting into shape for an occasion of some kind, then we can envisage, these drugs being used for that purpose. I guess that's already happening.
Lecture, isn't it? That's another public lecture, James, because now there's going to be a lot of pushback around that. I think the one thing that I would like people to begin to take away, what Sadafa Faruqi said, when they went for her fellowship, and everyone laughed at her talking about the metabolic control of body weight, is that this is a biological system in the way that blood pressure is, cholesterol is, heart disease is, etc. There are other factors that can play on it, but it's a biological system. And I hope this will begin to take away some of the stigma of obesity.
When would the triple agonist retatrutide become available in the UK, and would they be in the formulary for secondary care use? Can they be accessed in private clinics?
I'm hoping that Dr. Ruslan is actually on the NICE panel. I mean, the way things work in the UK, the way things work in the US, the reason they get licensed in the US more quickly is that the FDA can license something and it doesn't have anything to do with who will pay for it. So it gets licensed, and if you can afford it, then what the FDA is saying, it is safe to use for that indication, and a doctor can prescribe it. It could cost $250,000, whatever it costs. So we don't know what it's going to cost. And tirzepatide has been a big problem because they've priced it so high in terms of cost that there's been a big struggle about how we might even license that one. That's the middle drug. So it's Lilly make retatrutide. They've got to think about what they're doing and how they're going to price it. And so this is the answer to your question is a business question. And it's also, what deal can they do with the NHS? And the NHS will do what they call the quality calculation. So they'll be saying, okay, you're going to charge us, £10,000 for this. but how much quality adjusted life years are people going to gain if it's actually going to stop people getting diabetes and heart failure and eye problems? It's probably worth it actually to the NHS. And so the company's going to sit there saying, what can I get away with? And the NICE is going to say, well, you can only do it to people who are over this weight or with that particular problem because they've got something to gain. So I don't know when all that negotiation will happen, but I'm sure it's going to happen pretty quickly because these are very effective drugs. And I think it will be wrong for the NHS not to entertain them at all.
Okay. Colin, what specific advice would you give regarding the advisability of these drugs for children and adolescents? Is there, again, a danger for people with disordered eating patterns, that kind of thing? What are your thoughts on that?
Yeah. I don't know. And it's a great question to have. So when you start by having something like this, I also remember the introduction of the drugs for impotence a while back, and everyone said, we've got to limit it to people with spinal problems. But of course, Viagra is very widely available and has helped a lot of people. There's always a chance. The more people you treat, the more chance of doing harm at the edge. And that's a really important thing. That's why the doctors are involved, because they need to make these judgments. So clearly, people who've got an eating disorder, this is not a safe drug to use. And of course, it would be attractive for them to try and get hold of. We'll have to understand what the risks might turn out to be. It's something that can be stopped and reversed. But exactly as that question is saying, weight and food is so tied up with our body image now that these things will begin to interact. But I would just say, bear in mind the number of people who've had private surgery for weight loss. I'm not going to say mutilating surgery, particularly major things like that. The fact that this is reversible means that at least you can pull back from what you've done.
Yeah. Is it possible to overdose on these drugs? What might be the effects?
You'd be as sick as a dog. I mean, they do cause nausea. There's no two ways about that. So there's a maximum amount you can take. And in fact, it's surprising that you can take the dose that you can. The belief, I didn't really go back into how tirzepatide is working, but after an hour and a half seminar with about 3,000 or 4,000 people in Hamburg a week ago, they concluded that they didn't really know, but probably it was acting as a super agonist of GLP-1. So it's acting like that hormone, but like 3 or 4 times what the body would normally make. So you can imagine at some point that will be not tolerable.
Do you imagine there will be any societal effects of lots of the population being on these drugs, e.g., a change in attitudes towards diets or judgment around obesity?
Well, I'm very much hoping that's going to be the case. And that's really why I wanted to give this lecture when you asked me about it. Because, I'm just hoping that is going to at least change attitudes.
But couldn't it be the reverse, though, Colin, that people then become more judgmental and saying, why aren't you taking these drugs?
I'd love to see what happens. I mean, one of the things I find most interesting about the statin story is that statins are so easy, so available, so incredibly safe. They are the most miracle drug. People won't believe me, but they are in terms of the number of people that have been helped by it. That there's a lot of people who are anti-statins. And I'm not going to take that. It's not natural. I don't want to do that to my body. So people tend to push back at a certain level, and that's natural and normal as well. I would just say one of the questions in there, Mounjaro is tirzepatide. So it is that next generation of drug that I talked about.
Can you just quickly recap again for the audience? How long would you need to take these drugs to make a difference?
Oh, you see a difference in a few weeks. Yeah. It's very quick in terms of action. You can see that a lot of the benefit is seen within 6 months. So it works very quickly. And it is a remarkable thing. If you don't eat, you do lose weight. And that's how it's driving it. It's not through burning up the calories.
Because there's an intriguing question as to whether some of these drugs might be used as a treatment for degenerative brain diseases such as Alzheimer's and other forms of dementia.
We're sitting in diabetes where everyone's stealing our drugs, right? This is our drug. What are you doing? And I went to, talk a year ago in Parkinson's disease because there are GLP-1 receptors in other neurons in the brain. And there's certainly evidence in Parkinson's disease that some of these might be helpful. and they're just trying the first generation, the Exendin now, in Parkinson's disease. So I think we will find other uses, whether it requires different doses or different formulations. They are, in the end, brain drugs, although they have some side effects on the gut as well.
So if the stomach is removed from the body, how were they able to digest what food they did eat without acid production from the gut?
Well, you can get away with it. I mean, loads of people are on what we call PPIs, proton pump inhibitors, because of indigestion, and they almost obliterate the amount of acid from the stomach. It's amazing, isn't it, what you can get away with, actually? And people for years had operations, partial gastrectomies for stomach ulcers. So although acid is important, it's clearly not essential.
Okay. Can weight loss drugs have an impact on a person's metabolic rate?
So you're asking the question, do these drugs have an effect on metabolic
Yes. Can
rate?
weight loss drugs have an impact on a person?
There may be some others. One of the reasons that I mentioned that glucagon, do you remember glucagon came into the third drug? And that was because glucagon does stimulate metabolism, and they thought that may be how it's operating. Currently, they don't think they've given it in quite the right way to do that. So generally, no, that these drugs are not operating through metabolism. But you can imagine if you could add in something that affected metabolism as well. People in another field of endocrinology working on thyroid hormone have been trying to find analogs of thyroid hormone, because we know that thyroid hormone stimulates metabolism, but it also stimulates the heart and has risks. Trying to find a version of it that you can take safely. But at the moment, we don't have, if you like, a metabolism stimulant.
Colin, I'm conscious of time, so I think we'll just have a couple more questions. Do the drugs have the same effects on vegan diets or people who might have other dietary requirements?
I don't know. I know the answer to that question. And remember that the clinical studies will be a few hundred, at most a few thousand people. So that's what happens when a drug gets marketed. Then hundreds of thousands, as James pointing out, 1% of Denmark, which is already 50,000 people, take these things. And then you find that it has different effects in different people. I think really the key here is calories. Did I show you that picture of the cell, which is able to detect different things in lipids and short and long chain? And that's what drives the release of these peptides. So undoubtedly, different foods have different degrees of satiety. So often very rich foods. One of the things I believe about the French diet is that they don't have as much carbohydrate, but they do have rich foods. They eat very slowly. You often have a cigarette in the middle, and that reduces your appetite. So you actually end up consuming much less calories than a classic Welsh diet, where they have the chips and the rice as well as the curry, and the whole thing's on one plate, so you can demolish it within 5 to 10 minutes before it's even got anywhere near the small bowel. So I think that, and obviously vegan diets tend to be digested more slowly, so they may have less of an impact, but we wait to see.
And then could you just clarify for us again, please, Colin? We've been told that there's rapid rebound weight gain on stopping these drugs. Is that true or not?
Yeah, it does look like that's what happens. I showed you the one with setmelanotide. I don't know that I have any direct data on what happens in discontinuing these drugs, but certainly clinically that is what you see.
And then finally, last question, I think, for tonight, Colin. If these drugs become widely used, is there a possibility that the drugs will affect the profitability of selling calorie-rich foods with a secondary public health benefit on the obesogenic environment?
Well, I'd like to see that less people will be queuing at McDonald's late at night because they just won't be interested. So yes, it could have that kind of effect. And remember that losing weight is not just not just a vanity exercise, a vanity thing. The less weight you carry, the more physically active you can be, and it affects things like your joints and so on. So you can actually engage in many more things. Some people are pretty much housebound because they're so overweight, and all they get is abuse from people saying it's because they're lazy and they eat too many things and so on.
That's a really important note, I think, to finish off on this evening, Colin. So I'd just like to thank our audience for the excellent questions that we've had submitted. There's been some excellent feedback coming through as well for you, Colin, that people have really appreciated having your insights and time this evening, myself included. So many thanks again for a wonderfully paced and informative presentation this evening. That's been much valued by all. I think my colleague is now going to just share her screen with us to remind us that our next talk will be on Thursday, the 16th of November, where we have Dr. Neil Stevens from the University of Birmingham. This talk is in conjunction with the Wales Gene Park, and the title of his talk is Let's Talk Cultured Meat, Reflections on the Sociopolitics of Growing Meat in Vats. I'd also like to remind everyone that you will shortly receive an email with a link to provide us, hopefully, with some feedback for this evening's lecture. So we really do appreciate your feedback. It's really important that we get your feedback in order to ensure that this lecture series is sustained. So diolch yn fawr iawn, Colin. Diolch yn fawr iawn, pawb. Thanks, everyone, for this evening, especially Colin. And we look forward to seeing you again in a month's time. Nos da. Good night now. Bye-bye. Nos da, Colin.